This week's lecture will meet the course objectives by firstly identifying prevalent communicable diseases and their current epidemiology and routes of transmission in Canada. Secondly, recognizing the control and prevention by current public health policies, practices, or regulations. Thirdly, recognizing relevant laboratory techniques and tests used to culture, identify, and classify human pathogens and relevant terms encountered in reports or in the literature. And finally, understanding the major mechanisms used by microbial pathogens to cause disease. This week, we'll look at a handful of reportable communicable diseases that are included in the routine childhood immunization program in Canada, which are chickenpox, pertussis, mumps, measles, and invasive meningococcal disease. Rubella will also be included since it is necessary to be able to distinguish this disease from measles. We'll also be able to recognize the clinical features of these diseases and comprehend their pathogenesis, as well as identify the transmission routes and epidemiology of these diseases, recognize laboratory methods used to confirm their diagnoses, and recognize how the transmission of these diseases may be controlled and prevented. If we look at the incidence rates of a number of vaccine-preventable diseases over the past decade, chickenpox tops the list with a range of 2 to nearly 30 cases per 100,000 population. Pertussis, mumps, and measles have lower incidence rates, whereas the incidence rate of invasive meningococcal disease has been less than 1 case per 100,000. Rubella has an even lower incidence rate of less than 0.1 case per 100,000, as may be anticipated for diseases that can be prevented by immunization. The diseases marked by a red asterisk are the ones we will be covering in this lecture. We'll look at the viral diseases first, then the bacterial ones. Chickenpox is also known as varicella. After an incubation period of 10 days to 3 weeks, fever, headache, runny nose, and malaise presents with an itchy rash of fluid-filled blisters that last 3 to 4 days on the face and trunk. These blisters may fill with pus, rupture, and form crusty scabs before healing. Chickenpox has a much lower case fatality ratio of 1 in 100,000 in children than in adults at 1 in 5,000. However, complications can include pneumonia, encephalitis, secondary bacterial skin infections, and Ray's syndrome, which is very rare and associated with the use of salicylates. It can cause brain dysfunction and extreme drowsiness. Chickenpox infections during the first trimester of pregnancy may result in fetal death or damage. Shingles, which is also known as herpes zoster, is a reactivation of latent infection with the chickenpox virus decades after primary infection. The virus remains in the nervous system. It usually occurs in older adults and presents as a localized painful rash, usually around the waistline. Chickenpox is transmitted either by direct contact, droplet or airborne spread of blister fluid or mucosal secretions from infected individuals. The period of communicability is 1 to 2 days before the rash till all lesions have crusted over, which is usually 5 days later. Unlike measles, mumps, and rubella, the incidence rates of chickenpox were relatively high prior to 2010, and that is because the vaccine was the very last one to be included in the routine Canadian childhood immunization program in 2005. You can see from this epidemic curve that after 2010, rates dropped to baseline levels with less than 4 cases per 100,000 population and an average of around 500 cases a year. The rates in Ontario and Toronto also reflect this, averaging 385 cases a year, respectively. A case of chickenpox is confirmed in the laboratory by the isolation of the varicella zoster virus from an appropriate clinical specimen or the detection of the varicella zoster virus DNA. Alternatively, serological seroconversion with a 4-fold or greater increase in varicella zoster IgG titer between acute and convalescent sera, or a positive serologic test for varicella zoster IgM antibody can be used. Another criterion that may be used as an alternative to laboratory testing is clinical evidence of illness in a person who is epidemiologically linked to a lab-confirmed case. Clinical specimens that are required include blood or serum, skin lesions, or crust. PCR to detect viral DNA in skin lesions and crusts can also be used, as well as serological tests to detect a fourfold or greater increase in antibody titers between acute and convalescent serum collected 10 to 21 days apart, as required for one of the case definition criteria. IgM antibodies may also be detected to indicate recent infection. The chickenpox or varicella zoster virus belongs to the herpes viridis family in the varicella-virus genus. It is an enveloped DNA virus about 200 nanometers in size. It has a large genome coding for more than 50 viral proteins. Humans are the reservoir host. To the right is a picture of the virus, which always reminds me of a fried egg. The chickenpox virus enters the host via the upper respiratory tract and replicates in the lymph nodes. It then infects the skin, resulting in the characteristic blisters. It enters the peripheral nerves and remains latent in nerve cells. It can reactivate years later, producing new clusters of viruses that travel along the peripheral nerves to sensory nerve fibers in the skin, causing shingles. Treatment is supportive mainly, although salicylate analgesics such as aspirin should be avoided, as this has been linked to Ray's syndrome. Calamine lotion and colloidal oatmeal baths can be used to relieve itching. Acyclovir can also be used to treat infections in adults and pregnant women. Chickenpox can be prevented with a vaccine. In Canada, the National Advisory Committee on Immunization recommends the vaccination of all children at 12 to 15 months of age, followed by a second dose at either 18 months or older. Priority adult groups include non-pregnant women of childbearing age, household contacts of immunocompromised individuals, and high-risk occupational groups, such as healthcare workers and childcare workers. Immigrants and refugees from tropical regions that do not have chickenpox immunization programs should also be vaccinated. However, the vaccine should not be administered to pregnant women, and pregnancy should be avoided for at least a month after receipt of the vaccine. Measles is also known as rubeola, although very few people use this alternative name, as it tends to be confused with rubella, which is another disease we will review in this lecture. After a week or 2.5 weeks, a cough, head cold, eye infection, and fever develops. After onset of symptoms, reddish spots appear inside the mouth, and then a rash progresses from the face to the extremities for about a week. This is accompanied by fever and swollen lymph nodes. It is the complications that accompany measles that make this disease dangerous and sometimes life-threatening, especially in young children. Bacterial superinfections can occur in around 10% of cases, which affect the ear and sinuses or lungs. Severe infections can result in sepsis, which is an unusually severe response to an infection. Encephalitis, the inflammation of the brain tissue, may also occur with significant mortality rates and also irreversible neurological damage, such as deafness and intellectual disabilities. Due to the low blood platelet levels, bleeding into the skin and other areas may also occur during the acute phase. Measles is transmitted by direct contact with or inhalation of the secretions from an infected person's nose or mouth. The period of communicability is around 4 days before to 4 days after the appearance of the rash. Measles is very contagious with high infection rates. 90% of close contacts in households and schools will become infected. The R0 or reproduction number of measles is between 12 and 18, making it one of the highest for communicable diseases. The virus can remain viable in the airspace of an infected person for 2 hours after their departure. All age groups can be affected, but it has the highest attack rate in children older than 6 months. Measles is a disease that is a serious pediatric health problem in low-income countries, causing the death of 1 million children each year. Vaccination programs have been successful in decreasing the rate of transmission by 99%. However, outbreaks still occur due to one-dose vaccine failures and lack of immunization. So 2 doses of the vaccine is now included in immunization schedules. Like the rest of the world, the Canadian measles epidemiology has been influenced very significantly by routine childhood immunization programs. Before the introduction of the measles vaccine in 1963 to 1964, measles incidence followed a cyclical pattern with peaks every 2 to 5 years. Since the introduction of the vaccine, the incidence has decreased considerably. Further decreases were seen following the introduction of routine one-dose measles, mumps, rubella vaccine in 1983, and the introduction of routine two-dose MMR vaccines in 1996 to 1997 in the provinces and territories. With routine vaccination, the incidence of measles has declined by over 99% from an average incidence rate of 373 cases per 100,000 population in the pre-vaccine era to 1 case per 100,000 population from 2011 to 2015. Measles was not nationally notifiable between 1959 and 1968. As we saw on the previous slide, the measles incidence rate has dropped to baseline levels. In the past decade, the Canadian rate has fluctuated between less than 1 to 2 per 100,000, which corresponds to between 9 and 752 cases a year. Increased rates have been observed in some years. These are due mainly to community outbreaks caused by imported cases that were travel-related and subsequently secondary transmission. I will provide more information on these outbreaks in the next few slides. The Ontario and Toronto rates have been much lower than the Canadian rate and have not been above 0.5 per 100,000 in the past decade. The highest number of cases in Ontario was 22 in 2014 and 10 cases in 2015 in Toronto. As I mentioned in the last slide, Canadian reported rates in the past decade have been imported, and there has been no evidence of endemic transmission in Canada. The latest year with available annual data was 2018, during which the incidence rate was 0.1 case per 100,000, corresponding to 29 cases, which is below the median number of cases since the disease became reportable in 1998. 24 of these cases were severe enough to have hospital records, and 11 were admitted as inpatients. 6 of these hospitalized cases were not vaccinated, but 2 had received both doses of the vaccine. In 2015, most of the cases were associated with an outbreak in Quebec. The index case was exposed to measles during travel to a Disney theme park in California. There was then secondary spread to 158 others in the community to which the index case belonged, which was religiously opposed to immunization. There was also a much smaller outbreak in Ontario in the same year. The index case could not be identified, and cases had no epidemiologic link to each other or to a known case except for 6 cases that were household contacts. The close onset dates and identical virus genotype suggested that there was likely an association between the cases. This phylogenetic analysis shows that all 20 isolates in the Quebec outbreak had identical nucleoprotein gene sequences at a 450 base locus called N450. This sequence was also identical to the GenBank B3 genotype reference strain. I've indicated this by using a red box to group these viruses together. Although the results are not included in this phylogenetic tree, cases in an outbreak in California associated with Disney theme park visits also had the same N450 gene sequence. Let's look more closely at the Disneyland outbreak due to its connection with the Quebec outbreak in 2015. The outbreak started in late December and continued on till early February, resulting in 110 cases in California. Notice that there were actually more cases in Quebec than in the original outbreak in California. More than a third of the cases visited one or both of the Disney theme parks in mid-December, and nearly another third were secondary cases who were mainly close or household contacts. 45% of the cases were not vaccinated. The source of the initial Disney theme park exposure was not identified. However, the CDC inferred the potential source to be most likely from a massive outbreak in the Philippines in 2014, which had more than 50,000 cases based on the identical B3 genotype sequence of the isolates and the high proportion, nearly half of the imported cases in the US that were associated with travel to the Philippines during that time. The 2014 peak was actually much larger than the 2015 one. This was due to a very large outbreak in an unvaccinated community in British Columbia. There were 433 cases. The index case was an imported case from the Netherlands. Once again, the outbreak occurred in a religious community that was opposed to vaccination, and 99% of the cases were not vaccinated. The outbreak in the Netherlands started in 2013 and had more than 2,500 cases. Aside from this community outbreak in BC, there was another in Alberta in 2013, which was also linked to this outbreak. Notice that the genotype of the outbreak-causing strain was D8, which is different to the one that caused the Disneyland outbreak, and it indicates that these outbreaks were not associated. There was also a small cluster of cases in Toronto, which were associated with a childcare center in 2013. The index case had no travel history, and the source of the exposure was unknown. All cases were children below the age of 5, and 3 were not vaccinated, whereas 2 were fully vaccinated. The isolates had the B3 genotype. In 2011, there was a large outbreak in Quebec with 725 cases. The initial cases were imported, and secondary spread started in a school and then in the community. Most of the cases were concentrated in 2 neighboring regions and mainly affected older children between 10 and 19 years of age. The majority of the cases were not considered immunized, and less than a fifth were considered protected. A small proportion had only received 1 dose of the measles-containing vaccine. A case of measles is confirmed in the laboratory by the isolation of the measles virus from an appropriate clinical specimen or the detection of the measles virus RNA. Alternatively, confirmation can be made serologically by seroconversion with a 4-fold or greater increase in measles IgG titer between the acute and convalescent sera, or a positive serologic test for measles IgM antibody using a recommended assay in a person who is either epidemiologically linked to a laboratory-confirmed case or has recently traveled to an area of known measles activity. Another criterion that may be used as an alternative to laboratory testing is the presence of clinical illness in a person who is epidemiologically linked to a lab-confirmed case. Clinical specimens can be oropharyngeal or urine specimens collected within 5 days of onset. The specimens are cultured in cell lines and observed for multinucleated giant cells. Reverse transcription PCR can also be used, as well as serological tests such as hemagglutinin inhibition tests or ELISAs to detect a 4-fold or greater increase in antibody titers between acute and convalescent serum collected 10 to 14 days apart, as required for one of the case definition criterion. The measles virus is a member of the Paramyxoviridae family in the Morbillivirus genus. It is an enveloped single-stranded antisense RNA virus with a number of important functional proteins, such as the matrix or M protein for viral assembly, hemagglutinin for attachment, the F protein for cell fusion, hemolysis, and viral entry into host cells. It does not have neuraminidase. There is only one serotype that is pathogenic to humans. However, antigenic drifts occur over time, so molecular epidemiology studies are used to track outbreaks and their origins. 19 genotypes have been detected since 1990, and these are denoted by alphabets followed by numbers. Reference strains are also named as MVI or MVS, depending on the source of the isolate. MVI is used for sequences derived from RNA extracted from measles virus isolates in cell culture, and MVS for sequences derived from RNA extracted from clinical material. Then forward slashes separate the city and country of origin, the week and year of the onset date, and at the end, the genotype is added in square brackets. I've provided 2 examples of these, and you've seen one of the B3 genotype reference strains before, as this is the one that many of the Disney-associated outbreak strains shared identical sequences with. The host cell receptor for the measles virus is CD46, which is a cell surface marker that also functions as a regulator of complement activation in host immune responses. The virus attaches to host cells in the upper respiratory tract and replicates intensely in the respiratory mucosal epithelium, causing destruction of host cells. Cell fusion and formation of inclusion bodies occur. The virus disseminates throughout the body to lymphoid tissues, bone marrow, blood, and skin. There is a profound depression of cell-mediated immunity with decreased cytokine and antibody production, impairment of natural killer cell and polymorphogenesis, nuclear leukocyte activity, and increased susceptibility to bacterial superinfections. Lifelong immunity to reinfection is associated with the presence of neutralizing antibodies. There are no specific therapies available for measles. Supportive measures can be provided, such as analgesics to reduce fevers, and also bed rest to help with recovery. Cases should be observed closely, though, for any development of complications. Measles can be prevented by a live-attenuated vaccine. In Canada, the National Advisory Committee on Immunization recommends that children receive one dose of the measles vaccine at 12 months of age, followed by a second dose at either 18 months or at 4 to 6 years of age. All vaccine strains are genotype A. The PAHO target for vaccine coverage is 95% for measles elimination, with one dose of the MMR vaccine by 2 years of age and 2 doses by 7 years of age. Unfortunately, these criteria have not been met in Canada, and the coverage is only at 90%. The measles-containing vaccine is also recommended for susceptible adults, such as students in post-secondary educational settings and travelers to destinations outside of Canada who were born in 1970 or later. Although adults born before 1970 are presumed to have acquired natural immunity to measles, the vaccine should be administered to several occupational and recreational groups, such as non-immune healthcare workers and military personnel, regardless of when they were born. The next disease is mumps. It has a long incubation period of more than 2 weeks, after which fever and swelling of salivary glands either on one side or both sides of the face occurs within 1 to 3 weeks of onset. Complications include mild meningitis in approximately 10% of cases and severe encephalitis, pancreatitis with abdominal pain and vomiting, testicular inflammation in 20% of males, which may lead to infertility in a few cases, and rarely ovarian inflammation in females. Mumps is transmitted by direct contact with or inhalation of the secretions from an infected person's nose or mouth. The period of communicability is 7 days before to 9 days after onset of illness. Mumps affects all ages, but mainly the 5 to 15-year age group, and before vaccines were available. 85% of the population have been infected by adulthood. After measles, mumps is one of the most contagious viral diseases, with an R0 or reproduction number between 10 and 12. However, only a third of infections are clinically symptomatic, with the characteristic visible facial swelling. Mumps was a very common disease in Canada from 1924 to 1958, with incidence rates ranging from 52 to 449 cases per 100,000, with peaks occurring in a cyclical pattern. No data is available from 1959 to 1985, as the disease was not reportable during that time. The mumps vaccine was approved in Canada in 1969, and the second dose of the measles, mumps, and rubella vaccine was added to routine immunization programs in all provinces and territories in 1996. After the vaccine became available, the incidence of mumps was substantially lower, with a steady decrease to baseline levels. However, increase in incidence was observed in a number of years. Since the introduction of the routine second dose of the MMR vaccine, there has been a change in the age distribution of mumps cases. The highest incidence rate was in 20 to 24-year-olds, and there was a decrease in reported cases in children under the age of 10. Most of the outbreaks were associated with college or university students who only had one dose of the mumps-containing vaccine, and under-vaccinated communities opposed to immunization for religious or philosophical reasons. After the addition of the second dose to routine childhood immunization programs, incidence of mumps dropped to baseline levels and ranged between less than 1 to 6 cases per 100,000 population, corresponding to 40 to more than 2,200 cases. However, some increased rates were observed at times. For example, in 2017, the rate increased suddenly to over 6 cases per 100,000. This was due to a large number of outbreaks that I'll talk about on the next slide. The Ontario incidence rates ranged between 0.1 to 1.8 cases per 100,000, corresponding to 13 to 260 cases, and the peak in 2017 is not as pronounced. However, for Toronto, This 2017 peak is very pronounced, indicating that one of the outbreaks occurred here. The Toronto rates range from 0 to 5 cases per 100,000, corresponding to 0 to 138 cases. As I mentioned on the last slide, the peaks observed in 2010 and 2017 were due to outbreaks. From 2016 to 2018, 25 mumps outbreaks occurred in 9 provinces, with 2,263 mumps cases reported in 2017. The majority of the cases were between the ages of 15 and 39 years, and a quarter of the cases were in the 20 to 24-year-old age group, which represented the largest proportion of cases. More than half of the cases were exposed during community or social gatherings. During this time, there was a massive outbreak in Manitoba with more than 2,200 cases. This was a prolonged outbreak which started at the University of Manitoba that lasted for more than 2 years. The genotype of this outbreak-causing strain was G, which is a different genotype to the vaccine strain. There were 2 mumps outbreaks in the NHL, that's the National Hockey League if you don't follow hockey in Canada. A small one in 2017 and a larger one in 2014 that affected 15 hockey players, including Sidney Crosby. The suspect index case was Corey Perry of the Anaheim Ducks, and the virus was then transmitted to other teams over a period of 3 months. There were several suspect cases in the St. Louis Blues team who had flu-like illnesses. However, this was not confirmed to be mumps, even though the Ducks played the Blues in a match in October 2014, when the outbreak first started. The Ducks also had a match with the Minnesota Wild. There were also matches between the Wild and the New Jersey Devils in November, and it wasn't until December that the Devils had a game with the Pittsburgh Penguins that Sid the Kid was interviewed with a prominent swelling on the side of his face. There is a media video and a figure showing the chain of transmission between players and teams, which I might display during question time. What is interesting is that Sidney Crosby had already had 2 doses of the mumps vaccine, yet he was not protected. The case of mumps is confirmed in the laboratory by the isolation of the mumps virus from an appropriate clinical specimen, or the detection of the mumps virus RNA, or serologically by seroconversion with a 4-fold or greater increase in mumps IgG titer between acute and convalescent sera. Alternatively, a positive serologic test for mumps IgM antibody in a person who is either epidemiologically linked to a laboratory-confirmed case or has recently traveled to an area of known mumps activity. Another criterion that may be used as an alternative to laboratory testing is the presence of clinical illness in a person who is epidemiologically linked to a lab-confirmed case. Clinical specimens can be oropharyngeal, urine, or cerebrospinal specimens. These specimens are cultured in monkey kidney cell lines that then observed for multinucleated giant cells and viral hemagglutination. Reverse transcription PCR can also be used, as well as serological tests, such as hemagglutinin inhibition tests or ELISAs, to detect a 4-fold or greater increase in antibody titers between acute and convalescent sera, collected 10 to 21 days apart, as required for one of the case definition criterion. IgM antibodies may also be detected to indicate recent infection. The mumps virus belongs to the Paramyxoviridae family in the Rubella virus genus. It is an enveloped single-stranded antisense RNA virus with a number of important functional glycoproteins, such as hemagglutinin for attachment and neuraminidase for lipid membrane fusion to host cells. Although there is only one serotype, there are 2 major genotypes. The vaccine strain is genotype A, whereas most outbreak strains have the G genotype. After initial entry into the respiratory tract, the mumps virus replicates locally and progressively disseminates to target tissues such as the salivary glands and the central nervous system. Its spread and replication in the kidneys can result in live virus in urine specimens. The inflammation and swelling is predominantly due to mononuclear cell infiltrates. Mumps can be prevented by avoiding direct contact, including sharing saliva with someone diagnosed or suspected of having mumps. Also, avoid sharing drinking glasses or eating utensils. Good hand hygiene is essential, and covering mouths when coughing or sneezing is always good practice. There is no treatment for mumps. However, there is a vaccine available. As I mentioned before, the genotype of this vaccine strain is genotype A, but studies have shown that antibodies to this strain will also offer protection against other genotypes. It is really the waning of the immune response over time that results in previously fully immunized individuals becoming susceptible to infection. In Canada, the National Advisory Committee on Immunization recommends that children receive 1 dose of mumps vaccine at 12 months of age, followed by a second booster dose at either 18 months or 4 to 6 years of age. The mumps-containing vaccine is recommended for susceptible adults, such as students in post-secondary education settings and travelers to non-North American destinations who are born in 1970 or later. Although adults born before 1970 are presumed to have acquired natural immunity to mumps, the vaccine should be administered to several occupational and recreational groups, such as non-immune healthcare workers and military personnel, regardless of when they were born. Rubella is also known as German measles. The incubation period is more than 2 weeks, after which a low-grade fever, mild upper respiratory symptoms, and swollen lymph nodes present with the appearance of a faint rash on the head, neck, and trunk within 1 day of onset, lasting 1 to 3 days. The virulence of the rubella virus is low, so less than half of the infections have clinical symptoms. One of the most common complications is arthritis in joints, lasting less than 3 weeks. As I've mentioned in previous lectures in ENH 322, arthritis in children is rare, and this is a symptom that may indicate that a prior infection has occurred. Congenital rubella syndrome is the main reason why this disease is of concern during pregnancy. Transplacental transmission can occur, and there is a significant risk of fetal damage in pregnant women who are infected for the first time during the first trimester. Congenital defects vary from subtle to severe, such as cardiovascular and neurological defects, blindness, deafness, and other multiple malformations, and sometimes death. Rubella is transmitted either by direct contact with or inhalation of the secretions from an infected person's nose or mouth, or vertically transmitted from mother to fetus. The period of communicability is a week before to a week after the rash. Congenitally infected infants are important reservoirs in perpetuating virus transmission, as they can still shed virus 6 months after birth. However, rubella is not as contagious as measles. The R0, or reproduction number, is between 6 and 7. The graph shows the historical reported number and incidence rate per 100,000 population of rubella cases in Canada over several decades. The number of cases and the incidence rate of rubella followed a cyclical pattern, with peaks every 3 to 4 years, until the introduction of the routine 2-dose measles, mumps, and rubella vaccine during 1996 to 1997 in all provinces and territories. The average number of rubella cases reported in Canada decreased from approximately 4,000 to about 1,800 to less than 30 cases annually. In Canada, consensus on adopting the PAHO regional elimination goal was reached in 2005. From 2006 to 2011, an average of less than 5 cases were reported annually. The average annual incidence decreased from 0.2 per 100,000 to less than 0.005 per 100,000 in 2011, except in 2005. In 2005, the rubella incidence was about 1 per 100,000. This was due to a large outbreak in southwestern Ontario with over 300 cases. In the past decade, the incidence of rubella in Canada was very low, at less than 0.05 cases per 100,000, corresponding to less than 15 cases a year at the highest, and no cases at all in some years. In Ontario, only 4 cases have been reported in the past decade, with 2 in Toronto in 2 separate years. This is truly a story of success for childhood immunization programs. This is also the case for congenital rubella syndrome. 3 cases were reported in 3 separate years, and these were in babies whose mothers lived abroad. There have been no congenital rubella syndrome cases from exposure to rubella within Canada since 2000. We've not had any rubella outbreaks in the past decade, and the last one was in 2005 in southwestern Ontario that I alluded to on the slide with the historical epidemic curve. There were more than 300 cases, and 10 cases involved pregnant women. Most of the cases were children who had not been vaccinated. The community was philosophically opposed to immunization. We've seen this before with measles, with outbreaks that are largely restricted to isolated clusters of unvaccinated individuals who declined immunization for religious or philosophical reasons. A case of rubella is confirmed in the laboratory by the isolation of the rubella virus from an appropriate clinical specimen, or the detection of the rubella virus RNA, or serologically by seroconversion with a 5-fold or greater increase in rubella IgG titer between acute and convalescent serum. Alternatively, a positive serologic test for rubella IgM antibody in a person who is either epidemiologically linked to a laboratory-confirmed case or has recently traveled to an area of known rubella activity is also a criterion. Another criterion that may be used as an alternative to laboratory testing is the presence of clinical illness in a person who is epidemiologically linked to a lab-confirmed case. Clinical specimens that are required include respiratory secretions in acute phase and urine, tissue, or feces from congenitally infected infants. The specimens can also be cultured in cell lines to isolate the virus. Reverse transcription PCR to detect complementary DNA can also be used, as well as serological tests such as hemagglutinin inhibition tests, ELISAs, or indirect immunofluorescence assays to detect a 4-fold or greater increase in antibody titers between acute and convalescent sera collected 10 to 21 days apart, as required for one of the case definitions. IgM antibodies may also be detected to indicate recent or congenital infections. The rubella virus belongs to the Togaviridae family in the rubivirus genus. It is an enveloped single-stranded sense RNA virus with hemagglutinin for attachment. There is only one serotype, and the rubella virus is only found in humans. The virus enters the host via the upper respiratory tract, then replicates and spreads via bloodstream to distant sites including lymphoid tissues, skin, and organs. Inflammatory responses such as rash and arthritis present due to cellular immune responses and circulating virus antibody immune complexes. Fetal infections are particularly dangerous and persist after birth. Infected infants continue to shed virus in their throats, urine, and intestinal tract for more than 6 months and eyes for as long as 4 years. There is no treatment for rubella, and since the illness is mild and self-limiting, only supportive measures are required. There is also no specific therapy for congenital infections. However, a vaccine is available. In Canada, the National Advisory Committee on Immunization recommends that children receive 1 dose of measles, mumps, and rubella vaccine at 12 months of age, followed by a second booster dose at either 18 months or at 4 years to 6 years of age. In Canada, the rubella vaccine is only available in combination with the measles and mumps vaccine, as MMR, or the measles, mumps, and varicella vaccine, which is MMRV. These are the 2 different types of combination vaccines available in Canada. Note that the second type of vaccine also includes chickenpox. Both vaccines are live vaccines. The rubella vaccine is recommended for adults born in or after 1970 without a history of measles, and those individuals without evidence of immunity to rubella or mumps. Priority groups include non-pregnant women of childbearing age, especially those who are foreign-born, students and staff in educational settings, people who work with children, for example, child care workers and teachers, healthcare workers, and travelers to rubella endemic areas. Women should delay pregnancy by 4 weeks following vaccination with the MMR vaccine. Both the MMR and MMRV vaccines are contraindicated in pregnancy because there is a theoretical risk to the fetus. However, there is no evidence demonstrating a teratogenic risk of such vaccines.